Who would like to get us going this morning? Who'd like to start? As there was a bright and early group here. I think we should begin. Yes. All right, so just to introduce you to some of the frameworks very briefly for thinking about these themes, and again, there are a lot out there, but just so you can have a way of organizing, if you like, this building block in your mind. All right, so the health workforce building block, this comes from WHO's World Health Report in 2006, was on health workforce theme. And they basically summarized the issues around health workforce as a dynamic, actually as a labor market dynamic, really. So the one is entry, preparing the workforce, and all the issues around planning and human resource development, training, and then the recruitment of health workers. So, you know, the planning function would be, for example, the balance between different kinds of professionals, doctors, nurses, allied professionals, how you're going to bring Ayurvedic practitioners into the system, how you're going to distribute roles, scopes of practice between different players. Are you going to have a national community health worker program? So that would be a planning function. It would also be numbers. So how many do you need? And how are you going to distribute them? So how, what kind of policies are you going to implement, for example, to ensure rural retention of health workers? So that would be, all of that would be in the planning function. The education function is a huge element of health workforce and what happens in training institutions, both the formal education, undergraduate, if you like, basic training, but also how you organize systems of in-service and ongoing training. What kind of regulatory mechanisms are in place to ensure that people have continually upgrade their skills and their professional competencies. So continuing professional development. And then it would be then, once people are in the workforce, how you enhance their performance. And they've got here supervision, compensation, system supports, lifelong learning. And that, we've spoken quite a lot about the software of people in systems. So what is it that drives performance? But there are a whole lot of hardware systems, human resource management systems that would underpin that. Performance management, leave management, processes of transfer, of postings, all of those things would be part of formal human resource management systems and is a huge subject in and of itself. And then there's how you limit the exit or the attrition or how you manage that. And that's also questions of retention. How do you prevent people migrating from the beautiful Lakshwini Islands to the mainland of Kerala or to other countries? So there's a very big diaspora, I think, of Indian professionals. How you keep them in the country. Thailand, one of the senior policymakers in Thailand said, our graduates don't go to other countries. Okay, you don't see many Thai professionals in other countries. And he said is because we teach in Thai, we don't teach in English. And our graduates can't speak English. I think he was joking maybe. But that's an interesting idea. Some countries overproduce, like the Philippines is a net exporter of health workers. Cuba is another one. They overproduce health workers more than they need, so it becomes a form of economic transfer. So questions of migration, and then so from public to private sector, rural, urban, all of those key questions. And yeah, so it would be that dynamic. So people used to talk about planning, production, utilization was the old framework, but also how you manage this as, if you like, a labor pool, and then the outcome being availability, competence, responsiveness, and productivity. So that's a basic framework for thinking about HR issues, and one could look at each of those dimensions and research them. You could research each of them. So I've got a PhD student who's looking at human resource management functions at the district level, the formal hardware systems of human resource management. And it's amazing. It's like information systems. It's like this black box. No one looks at it. And it's actually really poorly organized in South Africa. So she was looking at how the human resource function and information, those data elements, need to increase if you're going to have decentralized authority, but also how human resource management functions are shared and aligned between line managers and HR managers, and the software of how you integrate hardware and software at a local level. All right, so this is, as I said earlier, rural retention of health workers is a big theme in health systems, and in health system preoccupation, in thinking, in people who work at a senior policy level, who are thinking about overall health workforce questions. And as Deepa quite well summarized, there's now regarded as a standard package of interventions that countries would implement and that would be recommended by global bodies such as WHO. So compulsory community service or bonding is a very, very common strategy, and I think it operates here in India as well. Is that right? Yeah. Okay. So so it's at state level. Yeah. And is there do people stick to it? Is there buy-in to that idea? Yeah, yeah. And so people try and buck the system all the time. Yeah. So compulsory medical service, community service in South Africa works quite well, actually. I don't know why, actually. But somehow you can't register unless you've done the community service, and you will get a rural posting if that's needed. And then so that's the stick. Then the carrot is offering postgraduate training, rural allowances, housing promotion, and then also building workplace culture that makes a rural hospital attractive. So building rural hospital leadership that creates environments. I mean, rural hospitals can be quite idyllic settings for people with small children. So when they start to go to school, that's inevitably a crunch moment. And then this last, rural recruitment, which, as I said earlier, has emerged as by far the most significant factor. And in South Africa, one of the managers of a rural district in my province said, if we've got someone we really like and want to keep in our service, we find a spouse for them who's a local farmer, who owns a farm, a wine farm, or something very attractive. And that's how we get them to stay here, is that we act as matchmakers, as managers. We're not just here to dish out incentives. We've got to think about the software issues. And it is about belonging, about feeling comfortable with that environment. And so as we've seen, the one study was a cohort study, a longitudinal study that looked at retention and attrition in rural areas. But there's been a huge amount, and if you look in the literature, you'll see quite a lot of studies that try to model packages of incentives. And that work is called discrete choice experiments. Have you heard of that word, discrete choice experiments? So that also comes from the field of economics. It comes from the theory of demand. And it comes from people who are involved in marketing, do discrete choice experiments. Defined as a quantitative technique for evaluating the relative influence of different product attributes on consumer choices. So I don't think if I came to India I would buy a car, because I'd find it too terrifying to drive on the roads. But in South Africa you can't get around in Cape Town really very easily public transport. So we buy cars. Okay. So when we buy a car, we have to make choices about what model size engine, fuel efficiency, diesel, petrol, color, leather seats, no leather seats. Am I into, is it a symbol for who I am as a person and my status in the world, a car? So it's not going to be one single attribute of the car. You actually want to look at a combination of attributes for your decision to purchase a car. And so the same would be for working in a rural area. You might look at a set of attributes rather than any one single factor. So and it's very commonly used to assess both patient and provider preferences. So in these agencies, NICE, what does NICE stand for? It's a British agency that looks clinical effectiveness. Excellence, yeah. So they do cost effectiveness analyses of different treatment regimens, say, for, high cost diseases. They'll have different options. And so they'll do discrete choice experiments with patients. So would you prefer something that is more effective, but you have serious side effects for 6 months, or something that has low efficacy but actually you can continue working? It would be, so those patient preferences, or something that you can get from your local GP, something that requires you to travel. So you would be given a set of attributes, and so you try and model preferences and then make resource allocation decisions on the basis of it. All right, so this is, you can't see that, sorry, but it's in your handout. But typically, so the way you do a discrete choice experiment is you would construct a set of attributes. So for working in a rural area, it would be some combination of those attributes I put out there. And then you'd say, if my salary increased by 20% over an urban setting, and I had a chance to do further study compared to the urban area, which one would I choose rather than an urban area? Or if your salary stayed the same and you had the others. So this is, you get a series of choice sets like that. And this one says that the salary would be the same. Oh, you would get a rural allowance that is about 30% more. The number of years before you'd have to study is the same. You can choose, okay, I can't quite read that, but there's a set of attributes here, and they differ from the urban facility in one or two criteria. And yeah, there's accommodation and there's different criteria. And then you say, I will choose this one or that one. Okay. So, and then they present all of these different choices, and then they do incredibly complex statistical modeling on it, and they come out with individual factors and sets of packages. And this is, so that's the same study, which was, so this was the questionnaire that went into that study. That was one of the choice sets. And then it produces an analysis like that. So predicted impact. So what they did is they took people who were graduating from nursing colleges, okay, before they were in rural, before they'd been posted. Okay, so they were trying to predict what would be the factors that would get them to work in rural areas. And it was a collaborative study, Kenya, South Africa, and Thailand. And this I know for a fact is that these are research collaborators who got together. So it's a program of research. So that's why those countries were chosen. And so they looked at rural allowances, housing, benefit packages, training opportunities, promotion, and then a combination of intervention packages. And they looked at the change between urban and rural. So what's quite interesting is like salary interventions. A 10% rural allowance did very little. So actually, if you really wanted to attract people, you needed to up the salary by 30%, okay? So that tells you the size of your rural allowance if you're going to use that as a financial incentive. but some of the factors really weren't that significant, and it differed by context. So that's a discrete choice experiment, and you'll see quite a lot of it in the health systems literature as well, being reported, and also quite strongly in the more economic side of it. So I think I saved this article in your Dropbox. All right, so any questions about that, or thoughts or ideas on human resource? Okay, so then this coming to then thinking about information. So this is from the Health Metrics Network that basically mapped the elements of a national health information system in a very simple framework like this. So a national health information system needs to collect information on the determinants of health, so that's your contextual information, socioeconomic and demographic factors, environmental and behavioral factors, and then there are a whole lot of health system elements of the information system, inputs, policy, financing, human resource, organization and management. Outputs would be your information system, service availability and quality, service coverage, utilization. So that's, in a way, the WHO building blocks. You can see all the different elements there. And then your health status, mortality, morbidity, disability, well-being, as your vital registration, but also as your health status surveillance system. Okay, so those would be basically what you'd expect in a national health information system. And something, Measure Evaluation, a USAID-funded project, has gone further than to talk about the performance of an information system. So that is just the what. A little bit like the description at district level was the what. Okay, so this is how you think about performance of an information system. So what we gleaned from that study is that the performance wasn't great, actually, between Ethiopia and India, that there was potential for much greater performance of that system. So how would one evaluate performance of a routine information system? And so they're breaking it down. Here's your logic framework, your results chain, if you like. Here again, appearing inputs, processes, outputs, outcomes, impact. So you'd have routine health information system determinants. You'd have technical factors in the design of that information system you could look at. The complexity of the reporting system and procedures. Okay, so that was something we were suggesting might be an issue. The HIS design, the information system, the IT infrastructure, increasingly a determinant of performance of information systems. Then the organizational factors that influence. So here we're starting to get to software elements, cultural, management factors, governance, planning, training, supervision, quality, all of those organizational factors that influence how information systems work. The culture of information use. Okay, so that's getting to the deep, in what we'll call later the intangible software. Availability of, what does that say? Availability of something. And then there's a whole set of intermediate individual behavioral factors that influence the performance and use. Level of knowledge, data quality checking, problem-solving skills. So it's not enough to collect the data. You need to be able to solve the problems that the data highlights. Competence in human information systems, tasks, confidence levels, motivation. Those are all software factors. And then you've got the information processes, the use, data collection, data transmission, process, analysis, display, quality checks and feedback. And then that produces the quality information and its use. So that study didn't look at the quality of information at all. And then that leads to improved health and improved health status. Okay, so that's really a kind of framework. Conceptual framework that you could use to evaluate a routine information system. And they've very nicely put all of these into a set of tools. So you can see here, there's a diagnostic tool, there's a tool for looking at that, all of these have tools linked to them. So you could, the people in this district, I don't know why they didn't use the PRISM framework actually. I wondered whether that could have been something they could have used as well. So that's in your Dropbox. I saved that, the PRISM framework. And it's quite a, rapid evaluation, good MPH project, I think. Okay. So use of information is key. And another group that's written a lot about basic systems of management, like information, like human resource management, is Management Sciences for Health. Also USAID-funded group, big international NGO. Do you have MSH in India? Management Sciences, okay. So they've talk about the interface between the information and the management cycle. So that is the data collection, analysis, presentation, interpretation, and use. And the use is in planning, budgeting, implementation, control, monitoring, and evaluation. And that is essentially the management cycle. So it's really when information is integrated into these processes that it starts to become of relevance. So in decision making, okay, in making decisions about programs, about health services, about how to act, for example, at a district level, the routine information system is not going to give you all the answers. And there's a lot of answers that lie outside the formal information system that come from what people refer to as tacit knowledge. Okay. It's about the experience, the know-how, okay, that people have of local health systems and how to solve problems. So if you, as I'll show you just now, document, if you show that absenteeism is very high in facilities, that is not going to tell you how you solve that problem. And to solve the problem of absenteeism, you need to deploy a whole set of other understandings about why that's happening. What are the mechanisms to address it in that context? What rules can you draw on? What cultures of service delivery exist? What are the informal cultures? What goes down in terms of carrot stick and other mechanisms in that environment? It's like rural retention. Absenteeism is a wicked problem. So you need to draw on a huge amount of what we call tacit knowledge, experience, thinking, competence, commitment, and deed. And some would suggest that actually in problem solving or decision making, that formal information is just the tip of the iceberg, and that most of it is from other forms of knowledge that get deployed to the problem. And so we also had a PhD student who looked at this problem. Everyone says people in primary healthcare facilities don't use information. Okay, so we need to train them how to read an Excel spreadsheet. We need to give them more technical tools in information systems. And she went into primary healthcare facilities and observed and studied and immersed herself in that reality for a few years, in fact, and tried to understand why people don't use information. And she came out of it thinking, no, people use a huge amount of information. It's not that they don't use information. And what is that form of information? A lot of it was tacit knowledge. So she used this framework, okay, to try and understand that. So just to introduce you to a kind of refinement of the notion of software, if you like. So we've spoken about the distinction between hardware and software. So hardware, infrastructure, technology, finances, we can put the other building blocks there. There's something called tangible software, which is knowledge, management knowledge and skills. We could look at organizational systems and procedures, which the way things function, if you like, in the system, the more things that are more observable, but that are not bricks and mortar, but that are slightly more complex to understand. And then there's what's called intangible software. So that's the values, norms, relationships, communication, and power. So it might help to understand a little bit what I'm going to show you now. So what she did she did a very detailed analysis of the forms of knowledge required to manage absenteeism in health facilities. And it actually was action research. So she got people to elicit their tacit knowledge and to share it amongst facility managers. And what you got was this virtuous cycle of people being able to manage absenteeism over time much better. And she used one of the frameworks, I've forgotten whose framework this is, but that talks about, that tries to spell out different forms of tacit knowledge. So there's know-how, knowing how to perform or task or work within the system, the practical understanding of how to conduct a counseling session with someone who's absent, or how to interpret and apply the leave policy. Causal knowledge, knowing why absenteeism is high in a facility, knowing why an individual, so down to the individual, is taking excessive leave and why he's behaving and reacting in a certain manner. And know when. So being, timing is everything, and that's the understanding. And the time, knowing when to use a supportive approach and when to be more confrontational and corrective counseling. And so very nuanced forms of knowledge deployment that went with a more formal assessment of absenteeism that they were getting as well, which was actually quite inadequate for their purposes. So that was another problem of design. And so I'm sorry you can't see this either, but what she then said is, okay, so if you want to facilitate information use, you need to understand the balance between system hardware and software in information systems. And you need to understand, she referred to it as formal and informal information. So you need to combine different kinds of information. And so you need facility, you need health information staff, you need database infrastructure technology, health information systems training and development. So you need the information system, but then you need a whole lot of other things. Facility level management practices, so formal data collection, collation, validation, routine review of facility reports, control and rational planning processes. So you certainly need to have those processes at a facility level, but you also need to have observation of facility processes, active engagement with staff, active and accessible managerial presence, experimentation and emergent planning processes, individual and collective reflection as the software accompaniment that goes with all of that rational planning and data use. And so on she goes to the sub-district level processes. She looks at management, knowledge and skills, and she calls all of that tangible software, okay? And then there's the intangible software, valuing the use of information in monitoring and evaluation, rational decision-making processes, valuing information that is local and particular to the context. So often in these quarterly review M&E meetings, they would be presented with all the aggregated indicators, okay, and told, why haven't you met your target, okay? And here, what they did deliberately was to open space about the why questions that were very specifically about each facility. So they created space for people's tacit knowledge and experience to be expressed. So new forms of management and engagement, building trust to improve the quality of communication and learning. So working on relationships between managers and facility, between district managers and facility managers was a crucial interface. How that engagement happens, whether it's punitive, supportive, an inquiring one, or a compliance one, and working quite hard at the software of the relationships. Enabling supportive peer and supervisory relationships. So a lot of trying to facilitate horizontal sharing of experiences. And so what she documented was quite a profound process of what we call in the field double loop learning. So it was learning about how to do things differently, not just learning about absenteeism, but learning about solving problems and building confidence and an internal locus of control in these managers. So it started off with how do we improve the technical capabilities of managers, their numeracy and all of that, and it moved right along to very different kind of social processes that had then shift backwards into the use of information in quite a rational and classical way. So that was a long input on information, but I thought it quite important, given that it's an emerging area, that one thinks quite carefully about this as a social process. And that's the chapter, she wrote about that, that's the chapter, and that's the PRISM tool. All right, good. So we're done for today. Any questions, comments?